Thank you very much indeed, Elora, and thank you to those who've been putting questions in the chat, and hopefully Elora's talk will also inspire some questions in the chat. Thank you. If I could ask Kevin to come back on screen also, and we might just direct some questions to each of you in turn, both from myself and from the chat. An early question that came through, Tanny, I might give it to yourself, from Ruth Foley. She's wondering, very interesting to hear about the context of ableist views in relation to disabled people. How do you feel we can address what are often false assumptions and perceptions, Tanny?
Thank you. So I'd generally say I've been lucky. I've had some great doctors, but also I've been asked by doctors how I caught spina bifida. And I've also had doctors be quite judgmental about my impairment in terms of, oh, I wouldn't want to be like you. So I think it's a microcosm of society, really, which is a real challenge because, society, I said earlier, quite likes Paralympians, and we're almost like two different groups of people. Paralympians are lovely, and then the rest is quite seen as a drain on society. And I think some of the media coverage that we've had about, people wrongly claiming benefits and wrongly having a blue badge for parking all fits the narrative that disabled people are a drain on society. And I think people have to, question their own judgment about disability and impairment. And I was interested, a friend of mine's currently training to be a doctor in London, and they had a discussion yesterday about assisted suicide. And I think 68 out of 70 immediately put their hands up and said, actually, disabled people should be able to access it. So I think that's a real worry to me, that we've got a generation of young trainees who already have a limited view of disability, which, when we've seen in other jurisdictions, there's very little, recording of data. It's very easy for things to be signed away. Even if the legislation doesn't change, it'd be very easy to see how just somebody's view might be negative. And a colleague of ours, Jane Baroness Campbell, I think she was given a year to live 65 years ago. She's had quite a lot of, experience of discrimination within the health service. One of her doctors said to her husband, she's delusional, we might as well, we could let it slip away. He said, I've just been talking to her. And the doctor said, no, she thinks she's in the House of Lords. She can't be, she's disabled.
Okay. Thank you. As Tanya, you mentioned in your presentation that you've had representations from people who do have a disability, probably expressing views both in support of your own and challenging those. Now, you mentioned that some of the people who would challenge the views and would maybe support legislation would not be eligible to have their death their death caused as part of the legislation. Are there any compelling arguments that they do make to you and that give you pause for thought?
So I've only had 3 disabled people who've written and said, and it's all about choice, which is very... and they're people who come from actually a very well either strong financial or supported background. So the people who have been contacting me, I've had a few people contact me with MND who say, I want the job, but then they wouldn't fit the diagnosis of 6 months. And when they would fit the diagnosis, you've then got an issue of whether they have the capacity. I mean, there's some quite scary things suggested in this bill that, someone else could sign the form for you. And we've just seen the case in Canada where, very sadly, an elderly woman asked for to move into a care home. Her husband said he was tired of taking care of her, and she was euthanized that day. And so this is, people who wanted to change the law get very upset if you talk about a slippery slope. because we're told there isn't a slippery slope, but actually we see it in lots of other places. And I think it's that fear. I mean, there is a fear of what conditions like MND will do to you. And so instead of having support around people, people are demanding their choice.
Thanks, Danny. I appreciate that. Kevin, there's a question in the chat. I think I may know the answer, but in terms of the expansion of what they call medical assistance in dying in Canada, do you think there are any particular reasons that this has happened in Canada that might be different in other jurisdictions or countries in the future?
In one sense, yes, because the basis of Canada, the expansion has been legal. There's never been a vote for it in Canada. There's never been, the government has passed it, but only after the courts decided that it was part of human rights. So it's all connected to the Canadian Charter of Rights that was passed by Trudeau Sr. a number of years ago. So in that way, it's slightly different. On the other hand, it has a tendency to expand because you find that demand creates demand. We're forever hearing supply creates demand. This is demand creates demand, basically because you see people, if somebody has it for 6 months to live, a person says, well, I'm suffering more because I've got 12 months to live. And so therefore, the courts have listened to that kind of dialogue. So I think that's the mechanism for the way it expands. Already in Canada, you are seeing lawsuits. For instance, there's a lawsuit against a hospice that's basically the person is suing not for wrongful death, but for wrongful life because the hospice would not kill the person on their premises. And so but I think you would get lawsuits in this country and in Ireland, anywhere you will get lawsuits that expand the criteria. So I don't think it's just Canada.
Thanks, Kevin. Laura, can I come to yourself? One of the things I've been involved with and I've seen others getting together is how to bring together a coalition of people to broaden the group of people either outside of healthcare, outside of palliative medicine and palliative care. What do you think are the most important things about bringing a coalition of like-minded people together, as opposed to support one side of the argument in particular?
That's a really interesting question because I think people just think it's straightforward and simple. As Tanya said, they think it's a Hollywood death and that it solves the problem of bad deaths. So the campaigners in favour have got a really simple message, and our trying to point out the problems is very complex and in-depth. And I think that really we have to be saying that coercion is a real danger, and actually almost challenging them. Right, show us a bill that's safe. Show us a bill that will not be escalated, and then let's have a look at it. But please look at the bill. I found people who've come and really attacked me. I had somebody today actually who came and said, "Do you have no compassion at all?" Which was pretty aggressive. But when I sat her down and went through and referred to some things in the bill, it was quite clear she hadn't actually read the bill. So I think there is something about when people understand what's involved, they begin to go, ooh, actually, this is a bit tricky. And over the drugs, I did see somebody put in the chat about assisted suicide might be prolonged, but euthanasia is straightforward. Well, I hate to disillusion you, but the drugs used in euthanasia are a short-acting anesthetic agent, and in 2/3 of people, that's followed up with a paralyzing agent, a curare-like agent. The person's totally paralyzed, can't move a muscle, can't signal if they're beginning to reawaken from the short-acting anesthetic. they can't breathe because they can't move a muscle, so they die of asphyxia. And we know that when your oxygen levels begin to drop, that's a very powerful drive to pouring out adrenaline. It's the fight and flight response to be really alert. So actually, the chances of you having reawakened have gone up. But nobody's done the research to even verify that people are still sedated as they die. So I think there are real worries with the way this is being sold to the public as some sort of lovely, gentle, peaceful thing, because the person might look peaceful, but actually they might be absolutely terrified and alert. And it's worth remembering that some of these cocktails have been abandoned for judicial executions because they've been deemed to be cruel.
Thanks, Laura. And you're mentioning compassion earlier, touched on a question in the chat from a colleague, Marie Twomey. I suppose with the time that we've remaining in the Republic of Ireland, the Joint Oireachtas Committee on Assisted Dying sat between January 23 and March of the following year, and went through the first stage in our Dáil. The Dáil and Seanad are comparable to the Commons and the Lords in the UK. Historically, I think we've copied that also. I suppose it would be really helpful, I think, for the audience to hear some of your thoughts on, I suppose, how the bill assisted the bill in the UK is progressing, has progressed, and I suppose how the mechanisms that most of us who are not public representatives, what mechanisms are used to promote one opinion or to challenge, and how they are best harnessed, no matter what your point of view is. And either to yourself, Tanny, or Laura, if you wouldn't mind.
Well, I think we're seeing the proponents trying to use every trick in the book. They're trying to use every which way to get this through. And one of the difficulties, of course, is that you only have to win once to bring about the change. Those of us opposing have to win every time. So it's a real uphill battle. And there's all kinds of stuff going on behind the scenes. It's uncomfortable. Very, very uncomfortable. Tanny.
Yeah, I agree. The amount of pressure that we're getting to either withdraw amendments, speak less, behave differently in the chamber. There's lots of rumours around that we're filibustering. I mean, the big one is there's 1,000 amendments. Well, 2/3 of the debate in the House of Commons took place with the High Court judge as part of the process. Then it got dropped. To bring the High Court judge back in is 70 amendments. So, politics can be a little bit sort of unpleasant at times, but I think some of what we're facing here, and I guess my challenge is, I worked on there's domestic abuse legislation. We're constantly told things, well, okay, that's domestic abuse, but it won't happen in this bill, so, we've got stats in the UK, if a wife gets cancer, how much more likely the husband is to leave or not be caregiver, it's, I think somebody's posted about subtle coercion, that's a real challenge. And, everything we're getting, nothing is a barrier. Everyone should be able to access it and not taking into account the life that people actually live. And I think that's the disappointing thing for me. This bill doesn't exist in a vacuum of a perfect life in the UK. It exists in the society which we have, which on many levels, there's lots of discrimination, not just for disabled people.
Thanks, both.
Can I just say, Feargal, I think the other thing is that we need to get the message out loud and clear. This is not medical treatment. This is deliberately ending life. If you really want to have a service which is deliberately ending life of your citizens, then it comes under justice, Ministry of Justice, just like the death penalty did. It is not part of healthcare. You need healthcare to look after people, accept natural death, but actually do all they can to keep people comfortable and improve quality of life during that last phase of life and as they're dying, and also support the bereaved. But this is not medical care.
Yeah, thanks to Laura. And a colleague, Claude Regnard, argues that in terms of keeping assisted dying out of healthcare altogether. And you mentioned quite eloquently earlier that even a doctor or nurse or a healthcare professional using their position to raise the question of someone ending their life earlier or it being ended deliberately raises a question that they may not have considered. And then that can influence their thinking. And I think the other misnomer I've come across in practice is, in fact, that people like myself who are opposed to the legalization of assisted suicide will not discuss it with our patients. And in fact, that couldn't be further from the truth either. Kevin, I suppose one of the key points to your thinking and your thesis, and it's been raised in a number of the questions in the chat, is about autonomy. Would you say anything or a few words perhaps about the role of absolute versus relative autonomy in terms of potential influence on other people?
Well, I mean, not to get too far into the weeds, but there are different concepts of autonomy that have crept up. There's a sort of Enlightenment style autonomy that occurred in the past, what you'd call a classical liberal approach to things, which is tolerance. J.S. Mill, I'm thinking of. And there's a sort of relational autonomy that's come up more recently. So there's slightly different functions of autonomy. I mean, I think in relation to this question, autonomy is not as relevant as they like to think. First of all, because it's always limited. They never give autonomy to everyone. It's always certain people get autonomy and other people don't get autonomy. That strikes me as unequal. And it also says the autonomy is also sort of contradicted by the fact that relatively just about everyone can terminate their own life if they really wanted to, unaided. So the question of autonomy is getting another person's perspective. And I always think that the purpose of medicalizing, as Laura's completely right, sorry, Baroness Finlay is completely right, that this is anyway, sorry, I've lost my train of thought there. But yes, in terms of autonomy, I think the key thing to remember is that this isn't really about autonomy. This is about somebody else making a decision for you and then you having a menu choice. So it's sort of slightly separate from autonomy is the way I'd put it.
Do you want to come back in, Laura? Thanks, Kevin.
Yeah, I think the thing about autonomy is actually an illusion. If you're going to have a choice, you've got to have accurate information, you've got to have capacity to make the decision, and it must be voluntary. And if there's any element of coercion, it's not voluntary. So it's not a free decision. If you don't have accurate information, it's not a free decision. So if you haven't had information about everything that can help improve your situation, it's not a valid decision. And that seems to be really forgotten in the process. And also, what about the autonomy of the person you're asking to help you end your life? That just seems to be, it seems as if the view is, I want, therefore I get, and you must do what I say. And yet the bill is written to create an illusion of the doctors being gatekeepers on this. And that, again, doesn't feel right.
Thanks, Laura.